there's a part of your body that you might have never heard of, yet is one of the most critical anatomical structures. It's called fascia. It's essentially the connective tissue between all your muscles, bones and organs. It's everywhere, yet historically has been poorly understood. In recent years, however, there's been a huge interest in this peculiar connective tissue and the key role it plays in everything from healthy day-to-day living to Olympic-level sports. You're about to go on a fascinating journey, investigating the role that fascia plays in the human body, led by Robert Schleip, head of the Fascia Research Group at Ulm University in Germany. Dr. Schleip will be joined by a team of experts, including manual therapists, scientists and athletes, whose different disciplines will help us to understand fascia not just in an anatomical sense, but also the broader relationship it has with the natural world. We will see fascia under the microscope, in gross dissection, in animal studies, in the arena and in the wild. Emerging from this story is the idea that we, Homo sapiens, may be the most domesticated species on the planet, and that perhaps a lot of our problems stem from this unnatural lifestyle. Welcome to the secret life of fascia.
Fascia has been treated like a Cinderella in the whole field of medicine, not just in sports medicine. Compared with bones, compared with muscles, it has been neglected and virtually cut away. In medical dissections, this is kind of the initiation of any medical doctor all over the world, all over the Western world. This is usually in the second semester where you do the dissection course on human cadavers. The first thing to do is to cut all this white stuff away so you can see something underneath. One reason is, in the dissection room, this white stuff doesn't look very fancy. Also, you cannot cut it into countable pieces, this white stuff. And the male scientific mind, that's how we approach anything. We want to cut it into pieces that we can count, that we can give names, and then put back together and describe the functioning. That attempt is very futile, trying to do it with the connective tissue system that's overlaying your whole body, where you don't know where one piece starts and where the other piece ends. That is one reason why the connective tissue system has been neglected. The main other reason is because we couldn't measure it in a quantitative way. For the bones, we had X-rays. For the muscles, we had EMG, electromyography, so we could measure exactly which muscle portion is active at what part of the movement. For the fascia, we had subjective experience. I feel the tension here, you feel it there, or you have palpation from the practitioner from the outside. But that is very frustrating for a scientist if you're relying on all these subjective experiences. Now that has changed, basically because high-resolution ultrasound has made a jump forward, and now we can see tenths of millimeters, not just millimeters. And that's the threshold you need for fascia.
All our body, all our organs are formed just by four tissue. We have the epithelial tissue, the connective tissue, the muscular tissue, and the nervous tissue. The mix of the different tissue create the stomach, as the muscle, as the skin, everything. So the connective tissue is formed above all by fibroblast, collagen fiber, elastic fiber, and glycosaminoglycans and water. We can have a different type of connective tissue mixing these different elements in various ways. So if we have a lot of collagen fiber, we have, for example, a tendon. If we have a lot of cell and water, we have the loose connective tissue, and so on.
So we have two types of connective tissue. We have a loose connective tissue and dense connective tissue. So dense connective tissue is what we call like a collagen type 1, type 3. So it's what makes the tendon, the ligament, but also the layer of fascia. But fascia is not just dense connective tissue. There is also loose connective tissue. Loose connective tissue is glycosaminoglycans, hyaluronic acid or hyalurona in adipose cell. So basically it's the lubricant, the jelly substance that you have between the layer of fascia and between fascia and muscle.
So my genuine interest is, of course, how cancer grows in the body, how it infiltrates the tissue, and how we can stop that. But in order to understand that, we need to understand the connective tissue, we need to understand the tissue biology, and as such, we also need to know how fascia speaks with the connective tissue, speaks with the tumor, speaks to the immune system. It's an integrated unit that undergoes modification as the tumor progresses, but also as the immune cell fights against the tumor. So you cannot understand these diseases without understanding the connective tissue. Cancer cells, as they penetrate tissue, also break through fascias. They break through connective tissue, they rebuild it, they destroy it literally at some point. And so we are interested in the interrelation between those tissue layers, the tissue barriers, and how moving cells like tumor cells or immune cells that come in to fight against the tumor cells, how they are defined by the tissue organization and how they exploit tissue structures for their functions. As a consequence of this, we got to understand how the tissue works. And so for that we have an interest in connective tissue biology, as it is fundamentally implicated in different disease processes, like cancer and immunotherapy.
The tissues are what they are, and we put these labels on, and then that turns them into these things. I think when people call it fascia, they're thinking there's a dynamic, physiologically important organ, or tissue at least, that needs exploration. People who refer to it as connective tissue generally mean that it is merely connective tissue. It's the glue that holds the important things together.
One of the questions I would have is it a tissue? Is it an organ? Is it a system? It's obviously widely distributed and has specific and general effects. But as an outsider, if you will, who's got an interest in definitions, I'm really interested to see how it's classified. We have thickening of or proliferation of fascia and things like aponeurosis, but is that an aponeurosis or is it fascia, or is an aponeurosis constructed by fascia? And actually, that's one of the good things about fascia. It does challenge what is a structure, because as Robert Schleip said, we like to compartmentalise bits and pieces, put blocks together, but if something joins them, we kind of cut it away. We cut that white stuff out, it's obviously got some relevance. But how do you classify it is a really interesting question. We know what a peripheral nerve structure is. It's got axons, it's got blood vessels, it's got fat, it's got connective tissue, it's got an epineurium, perineurium, endoneurium, it's got mesoneurium, or related tissue. It's hard to know, and I guess a question for me would be, what exactly is it? For me, is it a structure, is it a tissue, or is it an organ?
In all my life, I heard about fascia because fascia was the topic of the work of my father. But I was really curious to understand how is the fascia, because in the common anatomical textbook, the fascia are not described. So in 2005, I had the great opportunity to do a lot of dissection in Paris. And in that way, I was able to understand really what is the fascia and how to dissect the fascia. The transversus muscle. So the fascia of the transversus muscle is considered different from the transversus fascia, but is a visceral fascia that connects the diaphragm with the pelvis.
What we started is to widen our understanding of the inquiry of fascial tissues. In the past, it was very unclear whether not only the epimysium, the envelope around the whole muscle, is considered as fascia, but if also the intramuscular connective tissue, which is called perimysium, or the endomysium, which is very, very thin, It's surrounding single myofibrils, and it has a high amount of collagen type 5, for example. So that is very similar to the loose connective tissue under the skin. And in Gray's anatomy, the loose connective tissue under the skin is called superficial fascia. But in the Terminologia Anatomica, which should be the most authoritative nomenclature, they said only dense sheets of connective tissue are considered fascia. So it was unclear whether loose connective tissue or only fibrous, dense, membranous layers are considered as fascia. Both of them are connective tissue. So we suggested that we go back to the Latin root of fascia, to connect, to bind, and we suggested to include joint capsules, to include an aponeurosis. In Gray's anatomy, an aponeurosis is not fascia. But if you look, for example, at the IT band here, which is an aponeurosis, if you go further below the knee, it becomes irregular connective tissue. Where does one stop? Where does the other continue? And it even continues into the collateral ligaments of the knee joint. It even continues into the knee joint capsule. So our suggestion was that all the fibrous, collagenous, connective tissues are considered as part of a body-wide fascial network. Whether you call them a ligament, whether you call them an aponeurosis, that depends on your loading style in the last couple of months.
Muscles are surrounded by an envelope of connective tissue, not only around the muscle, but also inside the muscle. Every single little muscle fiber has a little mini envelope of connective tissue around it. So the whole muscle is kind of invested in this multi-dimensional tube of connective tissue. So that's one thing. But the connective tissue doesn't stop there. It goes between each muscle, so it transmits the force from one muscle to the muscle next to it. We used to think that the force that a muscle exerts pulls on the tendon, right, and that pulls on the bone. Well, that's actually not the case. There's some really elegant recent research that's shown that a large component of the force that a muscle exerts goes laterally to the connective tissue around it and then to the muscles next door. It's distributed throughout the limb, very interestingly. And then the connective tissue doesn't just stop at the musculoskeletal system. It surrounds every single other part of the body, including veins, arteries, nerves, lymphatic vessels. Then it goes inside of organs, your heart, your liver, your lungs, your kidneys. Every single organ of your body has what we call a matrix of connective tissue. It's the scaffold. It's what makes the shape of whatever body part you're looking at. And it's a common denominator through the entire body. I mean, I find that's mind-blowing. You know, it's really there everywhere.
As I see it in the dissection process, the first layer of fascia you encounter is the superficial fascia, which is a fatty layer that has some dimension and sort of a spongy organization to its collagen fiber structure. We go to the second layer, and we're at the perifascial membranes, which is the interface that permits that whole fatty layer to shear like this. And it's kind of the anatomical basis of movement, that fascial layer. Its distensibility is permitting the relative movement of one layer of the body over another. Then we get to the deep fascial layer where those membranes anchor, and it plays out into a dense, regular fibrous network that's wrapping your muscles all the way to the bone.
Fascia is described as the muscular connective tissue, but I don't agree to that. Because the muscular connective tissue, the muscular envelopes, the tendons, etc., they are continuous with the visceral fascia. For example, particularly the anterior neck muscles are totally continuous with the mediastinum. So you could also do yoga-like stretches in order to loosen up the connective tissue around your heart and your lungs.
When I was doing some research about you, I was thinking, gee, the knee bone really is connected to the hip bone. And connected. To everything. Yeah, like to everything.
Yeah, and that's it. That's it.
So what happens without the connective tissue?
Well, the body would not be held together. I mean, it would just be these kind of disconnected organs and things that wouldn't possibly work together. So the thing that's intriguing to me is, why have we not seen it so far? Why? Well,
yeah, that's a really good question.
School,
yeah.
Right? You dissect the cadaver in medical school, you cut the connective tissue to get to the important things that you're supposed to be looking at, the veins, the arteries, the whatever. The connective tissue literally was ignored. It was this kind of gray stuff that
you just got out of the way.
You just cut through it. And sadly, that's also what happens during surgery.
Yes.
So this connective tissue is literally cut to get to the organs. And I have to say that's changing. A lot of surgeons now are paying attention to what they call fascia, which are the sort of layers of connective tissue, trying not to disrupt them too much, because they realize this is a new understanding now in surgery, that the fascial planes, the integrity of the fascial planes is important in the recovery process.
You know, as you're talking about this, I have gone in and videotaped open heart surgery and was completely unaware of the fact that there was this other layer, this connective tissue. I watched them open the skin, cut the sternum, pull the rib cage back, but I'm thinking, do I recall seeing this at all? It was as though it was...
it's hard to see.
Yeah.
It's hard to see because it's a little bit amorphous, but when you start paying attention to it, you start seeing the layers. And the layers are organized. They're not just kind of three-dimensional mesh. No. There's organization to it. There's a polarity to it, a directionality to the fibers, even though they're kind of woven, but there are different specific angles that these connective tissue planes take, and then they crisscross. It's very interesting. It creates these planes where you can stretch in one direction or another, either against the direction of the fibers or towards them. It's this whole science of this beginning to emerge to understand that.
Well, my understanding is fascia is a support system. So if a muscle contracts, the fascia around it can support it and help force. Protective, proprioceptive. That's the kind of approach I would have to fascia. But again, does it cause clinical problems? Sometimes, yeah. We know that peripheral nerve, for instance, you can actually get a hernia in your leg, where the fascia around the muscle, the peroneal fibular muscles, can rupture through its septum and press on the superficial fibular nerve. So that's an example of a failure of fascia in producing a clinical problem. But in terms of its overall function, must have specific effects locally, must have general effects. But most, my understanding is supportive, proprioception and movement control, force distribution and protection. They're the main aspects of how I understand fascia to behave, rightly or wrongly.
I think that the fascia is an organ. We can really consider it a new organ. And about this organ, we have to study the anatomy, the histology, the microscopic aspect, the function, everything about that new organ. But the fascia is also a network because as an organ, the key element of the fascia is connect also the different organs with each other, to connect the different muscles with each other.
The first appearance of fascia is that matrix, that mesenchyme, that primitive meso tissue. And we know in embryology that the body is organized. The organism is differentiating itself in fields, different fields of metabolism, different mechanical fields. There come differences in the body. Actually, the matrix is like a, really literally organizing medium along which the embryo, the body, the whole, the organism, is suborganizing its tissues. So I think that it were the Rovers who talked about the fascia as organ of form. Maybe it's the organ of formation or forming or shaping, and that literally is so. There are substances, via the spaces of the matrix, they organize the body in different fields. The three-layeredness of the human embryo, if you consider it to be three layers, and you name them ectoderm, mesoderm, endoderm, you count 1, 2, 3. And there's a very old science called the Tao, and the Tao also talks about 1, 2, 3, but it doesn't talk about 1, 2, 3. It talks about 1. The 1 becomes a polarity, a 2, and in between the two, there's the third. So the third, the 3, is not more of the same. It's not more of what you already had. No, it's something else. So now I count, or I say, it's not ectoderm, mesoderm, endoderm. It's ecto versus endo, with an in-between, and that's the meso. And that's the dimension of the third. That means that's the dimension of innerness, but it's also the dimension where the polarities, you know, polarity, part of my scientific thinking is polarity thinking, that everything in the body always is polarized. I can describe to you in the embryo more than 8 directions in which your body constantly is polarizing. And ecto and endoderm are representatives of that polarity. In my ectodermal body wall, I come in a complete different relationship with the world as in my endodermal visceral body wall. And the meso is the third dimension, which is as well sympathetic, as well antipathetic, connecting, as well disconnecting. And that is what I like in the model of 1, 2, thirds. So for me, it are no longer layers, it is just how your body is organized. 1, 2, polarity, thirds, in between. And then you're back at the 1. And that's what the Tao says. The 1 brings forth the 2 brings forth the 3, and the 3 bring forth all the many living beings living in the yang and the yin or whatever. I like that.
Well, so first off, there's the question of, are we talking about fascia or are we talking about interstitium?
Dr. Rolf saw fascia as almost a system unto itself, which was the organ of form. So the basic structural element of fascia is a collagen molecule. Collagenous tissues can diversify. They can get more minerals and become bone. They can get more fiber and become tendons, ligaments. They can become sort of soft sacs and enclose organs and support them. So fascia is ubiquitous.
We called it interstitium because it's fluid. That's how we came in. It was by the fluid because we have this fluorescent dye. The word interstitium means in between, basically. So it's just a descriptive term for things that are in between. What we found in our research is there is a larger space that we weren't expecting in tissues where we didn't expect it. So the lining of all the viscera of organs. So the middle lining of the whole digestive tract from the mouth all the way out the other end, the bile ducts, the ducts of the pancreas, the bronchi in the lungs, the airways of the lungs, etc. They all turn out to have spaces that in traditional histology, as we've developed it over the last 250 years, weren't known to exist. The reason they were not known to exist is because when you cut tissue out from an organ, a body, to make a slide of it, and I'm a pathologist, this is my bread and butter. I'm looking at slides of human tissues, biopsies and resection specimens every day under the microscope, and so hundreds of slides sometimes on a bad day, all prepared the same way. And all of them have this thing in common, that we are taking it out, the tissue dries, dehydrates, fluid flows out or evaporates, and we put it in a chemical like formaldehyde. And that cross-links the protein so everything becomes stiff enough that we can cut a very thin section, lay it on a glass slide, and then light can get through it. It has to be that thin, so it has to be stiff. So we have to process it this way. So when we do that, fluid that we may or may not have known is there dissipates. And what we discovered with a new technique where we could do microscopy in living tissues is that these layers that looked like dense walls of collagen layered on top of each other were actually more like a collagen lattice work supporting this fluid-filled space. And we saw this because this special microscope, it's at the tip of an endoscope, that we place down into the digestive tract and can see the living microscopy of the living tissue rather than this fixed dehydrated tissue on a slide. In order to see that, you have to put a fluorescent dye into a vein. And within a couple of minutes, that dye circulates throughout the entire body, filling and diffusing into every fluid compartment. So not only the veins and the arteries and the capillaries, but all the lymphatics, all the lymph nodes, and all this interstitial fluid. And when we look in the bile duct, what we saw was this open space. And when we look at the slides that I typically make from a bile duct, it looks like this wall. So what's the difference? And it took us a while to figure out that typically whenever you make slides of dense connective tissue, you get these little cracks between the collagen. And for 30 years I've been trained, and I have taught trainees, we've artifactually torn the tissue. We pulled the tissue when we were making the slides. So this was artifact and ignore it. And it turns out that's not artifact. The wall is the artifact. The real are these little spaces, which are the remnants of these larger spaces. And so suddenly we have this new interstitial space in the bile duct. Like, why would the bile duct have this weird interstitial space? So we were like, what makes the bile duct special? And that was a puzzle. But I'm a clinical diagnostic pathologist, so while I'm worrying about this, I'm also getting clinical specimens coming by me every day to diagnose. And I would get a cancer of the stomach and a cancer of the colon. And then I started to notice that this same layer in all those other organs, the entire digestive tract, there were cracks. And I realized, oh my God, those cracks are also this structure. So it's a digestive tract thing. So then I thought, ooh, a new thing about the digestive tract, it's not just the bile duct. And then I got a mastectomy specimen, and there's a skin portion. When a woman has a mastectomy, skin comes with it. And I looked at a section of the skin under the microscope because it's a routine thing, and I looked at the dermis, and there were the cracks. So I went down the hall to the endoscopist who first asked me about the bile duct, and I said, what happens when you put this special scope on the skin? Do you see the same pattern that we saw in the bile duct? And they said, it's an endoscope, we don't put it on the skin. So again, that's sort of, we're in our little boxes. So I said, well, inject some fluorescein into my vein, and I volunteered, and sure enough, the dermis has that same open structure. So that's what we were reporting. What we didn't know, because in allopathic medicine, in the United States and Europe, and generally around the world, we're all using the same textbooks, the histology says that's this kind of space. And fascia is sort of ignored. Oh, it's just connective tissue. And in the last few months, anatomists have said to me, why are you talking about this? It is just connective tissue. But then we found out, oh, there's this fascia world out here, and the osteopathic community, for whom fascia is a big deal, and they knew that it's this open space structure. But I think they didn't know that these other layers were also the same structure. So now we're realizing that from our different perspectives, we're getting a wider view of the body as a whole. And that's a meeting place for these different fields that have had a hard time talking to each other for generations. Suddenly there's a meeting point, and I think that's the most exciting thing. Meanwhile, what's the interstitium? So we have this intercellular interstitium, we have this pericapillary, small scale but larger interstitium, and now it turns out we have this larger interstitium, which is a same order of magnitude higher.
So this was always interpreted as artifact, that the collagen fibers had sort of split apart.
Right.
But this turns out to be the real thing that your skin lets us see. And the entire thickness of the bile duct wall is that, until you get into the fat around the bile duct, and there's fascia.
That's
and what do we see? It's the same thing. So if we do a collagen stain, here's duodenum, and here's the lamina propria, which lights up with your scope because there are tiny interstitial spaces up here, that perivascular scale.
Right.
And then we come down into the submucosa, and there are the collagen bundles with these spaces, and these spaces were thought to be artifact. But if your scope actually gets deep enough in, so this is, you know, a millimeter or two deep into the tissue, you'll see a reticular pattern as well. And this is what acts as a shock absorber. No one ever asked, how is it that dense connective tissue doesn't tear with decades or 100 years of peristalsis? It's because this is a shock absorber. It protects the tissue. Yeah.
the fascia lata here on the outer side, if you touch yourself there on the thigh, you should know what you have been doing in the last couple of months, because hopefully in most of you, the outside of the thigh feels stiffer, denser than the medial side of the thigh. Unless you have been in a wheelchair the last couple of months, then there will be no difference in stiffness. So this fascia lata is something that you develop not in 3 days, but over months of loading, strong loading. So the fascia lata that makes all the stiffness here that you can feel on yourself, and those of you who work with athletes, you know this is twice as stiff than in normal people. But how thick is the fascia lata in professional athletes? Most of the dense fascia are around 1 millimeter. So it can grow in thickness up to 1.5 millimeter. But nevertheless, the stiffness change you have is dramatic.
One size does not fit all. And while some people respond favorably to strong touch, other people respond favorably to gentle or soft touch. What was really interesting about the concussion pilot project that the Ricky Williams Foundation did with the Upledger Institute is that it concentrated on professional football players who respond well to a gentle touch therapy. That being craniosacral therapy, which would include the fascia to a large degree.
When I received the treatment the first time, there was a lot of time spent working on my head. And as a football player, all football players that have played at least into high school know that you use your head to play football. And there's a certain part in training camp where you get this really splitting headache, you know, when you first start hitting again. And you have those first couple hits and you just have this intense headache, and usually it'll last for 3 or 4 days, and then it kind of goes away. And so I've had concussions, but I never took myself out of the game because I wanted to play. So I knew that I had experienced a lot of trauma to my head, and I knew when I received the work that my whole body relaxed and I felt better and I was a better athlete. So just on the outside, the idea that, okay, that there's something that we're working with trauma and we're working with the head, it just, for me, that was the first thing. It's obvious football players can benefit from this.
Now, question, there are some people on this planet who don't have more stiffness on the lateral side, they have it on the medial side. Cowboys or cowgirls who are sitting on a horse 10-12 hours a day, they develop a fascial stiffness in the adductor magnus, including a bone spur. So like your heel spur, they develop a so-called rider's bone in the fascial part of the adductor magnus. So it means we have a whole body network of fascial tissues that specifies into hundreds of pockets, but also fiber lines, and where it thickens depends on your individual loading. You are not born with a fascia lata, although the fascia lata, the IT band, is what separates us from all other animals. There is no other monkey on this planet that has an IT band. It's a unique feature. It's the largest continuous piece of fascia that we have as Homo sapiens, and that's definitely related to our running and walking style. Starting in 2007 with the Fascia Research Congress that was sponsored by NIH, it came back to the scene of scientific attention. People like Andrew Taylor Still, the founder of osteopathy, people like Ida Rolf, they knew about the importance of fascia from their own observations, but it never made it into the stage light of international scientific attention.
Structural integration is a technique which aims at organizing, at ordering a body, at bringing muscles back into the place where they belong in terms of their theoretical order.
Andrew Taylor Still was a pioneer, and he stepped away from a system of medicine that tried to cure diseases by shooting magic bullets at the disease, and came back to an earlier model of health, which was that the resources for well-being were inherent in the structure. And in that sense, Andrew Taylor Still was a vitalist. He said, get it moving, get the circulation happening, and people will get better. And Rolf said, get people better organized spatially in the gravity field, balanced, and the person will function better. So in a sense, they're octaves of the same basic idea, which is a kind of vitalism. Still put the vitalism in the body. Rolf said it's actually in the gravity field. That if you get lined up with gravity, gravity is a friend to a well-balanced body. So the less you're struggling, the better the system flows, the more energy is available for well-being. That's the beginning.
In general, the difference between osteopathy and physiotherapy is that in osteopathy, the therapist is more active and the patient stays more passive. So if you have physiotherapy, it's just the other way around. The therapist is more passive and the patient is more active. Both are excellent therapies with a sometimes completely different approach.
That following this Congress, and the Congress was not just an accident, it was happening at the right time, because we had the measurement tools, because there were some hardcore scientific publications just in the previous years that convinced NIH to sponsor our application for this Congress, where we said if you bring once the leading scientists, not the clinicians, the scientists together to share their knowledge and questions about the field of fascia research, then you don't need to sponsor it in the future. Then it will become an international emerging field of research by itself. And basically that's what happened. If you look at the drastic increase in Medline Index publications on the field of fascia, also the journal Science, which together with Nature is #1 in terms of scientific rigor and respect, published a 2-page article. So those of you who are working in complementary medicine and you are striving for respect, you know, that your brother or your colleagues are saying, I do scientific work and you do this massage therapy there, get this 2-page science article and put it on their desk, and suddenly they will listen to it. It's a real door opener to us. It doesn't have any new information, but it's published in Science, and that makes a huge difference in respectability.
So what I'm going to be showing you today is the assessment that has developed both from clinical experience and also from a research trial that I did with the help of Professor Paul Hodges in looking at the behavior of the linea alba to different recruitment strategies of the abdominal wall. And what we learned from that study was that tension and not width was more important for function of the trunk and also for appearance of the abdomen. So Noel, without thinking of anything, no pre-contraction or cueing of anything, just bring your chin to chest and start to do a curl. So what you see is this doming in the midline, which is the laxity in the linea alba. I can push my fingers right the way through and I can actually pull the recti apart. So the depth of this is an indicator of how distorted the linea alba is. So this should be nice and tense, and there's none, and there's the doming. Down you go. So now at that area where there's the doming and the depth, the distortion, we sink through the EO, IO, transversus, pull our thumbs apart. Ask Noel to connect to her pelvic floor, which should give us a response in the TA, so I can feel the tension increase. Keep that, and now bring your chin to chest and curl. And you can see a lovely change in the doming. There's less doming. There's more tension in the back, although I can still sink in right here. Higher up it's less. I can still pull apart a little bit. So now I'm really interested in this area here and whether or not her transversus is able to generate tension in the linea alba and in those rectus sheaths. Down you go. Noel's linea alba at rest. Note the interrecti distance is 4 centimeters. When she does a curl up using her automatic strategy, note the left and right rectus come together, narrowing that gap, and the linea alba domes. The distance narrows to 1.12 centimeters, and there's no tension. When she contracts her transversus, note the tension arrive between the two recti, and the linea alba straightens. When she maintains the transversus contraction and does a curl up, tension is maintained in the linea alba, and the interrecti distance is 4 centimeters, and the linea alba is nice and tense, ready to transfer loads.
The tensegrity model. This has been an inspiration for many people in fascia research. That was inspired by the presence of Don Ingber at the first Fascia Research Congress, who is the scientific spokesperson for the tensegrity model.
My scientific career was really launched when I was an undergraduate student at Yale. I was a science student, but I always loved art, and I saw art students walking around with little sculptures that looked a lot like the viruses that I was studying in my class. And I asked them, what's the name of the class? And they said three-dimensional design. And I was working on molecular structure function, which is basically three-dimensional design. The shape of a molecule dictates its function, like the lock and key of an enzyme and a substrate. I got into the course, and the teacher one day had this sculpture that was made of sticks and strings. The sticks didn't touch, but they were suspended in midair by being connected with the string. And it was in a round shape, and as he talked, he would flatten it on a table, and he would let go, and it would bounce off the table. And it was called tensegrity. Tensional integrity comes from Buckminster Fuller and sculptor Kenneth Nelson. It's the way our bodies are built, with muscles pulling our bones up against gravity, and the tension in your muscles controls our stiffness. I could be stiff or flexible. That's tensegrity. But I saw this sculpture bounce up and down, and I had just by chance that week learned how to culture cells in a cancer lab. And cells grow flat on a dish, and if you want to move them to a dish, you use an enzyme that clips their anchors, and they bounce up off the dish and round up, just like that model. And I thought, oh, that's the way cells must be built. It was 1976, and the first papers were coming out that all cells, they're not balls of jelly or water balloons filled with molasses. They actually have an internal skeleton called a cell skeleton or cytoskeleton. And so I knew that they had these filaments, and I knew cells create tension, or muscle cells create tension. So I thought, oh, they must use tensegrity. And I went back to the cancer lab, and the guy I was working with, we were testing a drug, and it caused the cell to change shape. And I said, oh, the tensegrity must have changed. He said, what's tensegrity? I said, oh, Buckminster Fuller, art class, sculpture. He said, never say that again. And so, and shut up, and I basically went to libraries and read about it, and I began to realize that there's something here. That led me to think about physicality and the idea that mechanical forces may be as important as chemicals and genes for development. One of the properties of tensegrity, that as you apply force on it, it gets stiffer and stiffer in direct proportion as you apply more stress. That turns out to be a fundamental property of cells, tissues, molecules, and that's because basically tensegrity is used at all size scales in the hierarchy of life. And I called that the architecture of life in my Scientific American in '98. And recently people are confirming molecules are built this way. I confirm cells are built this way. Our body's built this way. It turns out tissues are built this way. So it actually is a fundamental design principle, and it's a principle that it's very broad, and it applies to all facets of biology and living systems.
So tensegrity has been proven to be a fairly accurate model to understand the biomechanical behavior of single cells. And many of us, we assume that you can also understand the whole human body better if you apply some tensegrity-like principles. So one of the principles of tensegrity is that you have a discontinuous arrangement of the sturdy elements, which are created to be compression resistant. So in the human body, it may be the bones. Here it is the wooden sticks. So in a real tensegrity model, they never touch each other. So they are isolated spacer. But you also need a second element, which is tensional resistant, which are the rubber bands here. And the beautiful thing in the tensegrity model is they are all connected. So if you have an appendix scar down here, it will affect even pieces that are far away. So everything is related with everything else, but to different degrees. But no element is non-affected. So if a movement is good or bad, or if it can be improved, depends how tentegral is it. Is the whole body participating, or are some portions excluded by it? So that model has not been proven to be correct for the human body, but we assume that a healthy body has more applicability of it. Of course, the human body has more elements. We have the liver, we have fluid-filled sponges in between. We are not just made out of rubber and of sticks. And we have the muscles who are pulling on it.
Biotensegrity explains how the principles of tensegrity manifest itself in biological systems, from viruses to cells to tissues of living systems. For example, plants and animals. Biotensegrity integrates complex anatomy and biomechanics to make sense of living systems and as a functional unit.
I have come outside to a children's playground. Here we have the Spider Gym, a very popular exercise equipment for children to hang off, and of course it looks a little bit like a tensegrity, but in fact it's not a tensegrity because it needs the ground. A tensegrity can operate in a gravity-free environment, and of course you and I are biotensegrities. So let me explain what that means. The major difference between a tensegrity and you and I, the biotensegrity, is that in the biotensegrity, rather than two members, there really is only one member, because remember, everything is connected to everything else. In embryological development, you grew yourself, you self-developed, and you self-emerged. And at no time did you need to have a lower limb or an upper limb, glued or stuck onto your body. You grew yourself, which tells us that there is only in fact one. Now we can look at the human body in an X-ray and we could see a bone like the humerus, or better still, the femur, and we can see that there's a definitive end. But the truth is that in dissection, we realize that we have to through the tissues in order to take a bone out of the body. So in biotensegrity, there is only one member, compression and tension.
Galileo in the early 1600s described 5 simple machines, and one of them was the lever. Borelli, who then developed the mechanical process of the body, was a student of Galileo, actually studied under him for a while. The story goes that Galileo didn't think much of Borelli and didn't appoint him to a position that he should have, but he turned out to be okay. But at the same time, he used these very simple system that Galileo talked about to explain what they saw as a mechanical system of the body. But the body isn't that same kind of mechanical system that we use in the world. And so you have to think of another system. So you can't use Newtonian mechanics to do quantum physics. You can't use the physics of a geocentric universe when you have a heliocentric universe. You have to use a different understanding right from the beginning. So once you recognize that this is a holistic system, like, you can't use levers anymore. So you have to bend in that whole concept, use a new concept, new math. This is, levers are hard matter, they are rigid bodies, they're revolute joints. They have a, system. They use gravity. You have to have gravity to use a lever. See, and not only that, if you have arm going this way, you have to do completely different math if you're doing it this way. You've got a system like this, and it's the same all the way around. The math is the same all the way. It doesn't make any difference. It all works together. But so you have to completely think how you use it, and you have to completely abandon the lever system and hard matter physics. It doesn't work in biologic systems because we are soft matter physics. You can't use the rules pertaining to hard matter that you can use it in fluids. You have solids, liquids, gases, and soft matter, and there are different laws for those. So you have to then say, okay, we now have to use soft matter physics to understand a biologic system which is soft matter. And those qualities include auxism, close packing, Plateau's laws relating to foam. Those apply. These other hard matter laws of Lever's don't apply. Normal Newtonian mechanics do not apply to gases and these things and soft matter. And it's that simple.
The body uses every kind of engineering that it can possibly use. It uses levers, it uses inclined planes, it uses tensegrity, it uses balloons and pneumatic types of structures. The body doesn't care whether it's pure tensegrity or pure levers. It uses everything that it possibly can do to make the most efficient animal that we have. Trouble is, we've put that animal in an environment that it made itself. We've put that animal that was honed in the jungles and the plains and the mountains and the seashore, and we've put that animal inside buildings. I don't know whether this is going to be looked at by people outside of America, but in America, a lot of the children are essentially under protective house arrest. They rarely leave surfaces that were made by the hand of humans, and they rarely get out of their shoes, and they rarely step on a floor that isn't a flat floor, again, fashioned by the hands of humans. We don't know what happens when we take a body that was designed for the Paleolithic world, the Neolithic world, and put it in the human zoo, put it in an urban environment. And we just don't remember mostly how new this is. That most of the world was out in the fields with a scythe or a sickle or in the rice paddies for the last 12,000 years, and that's even a drop in the evolutionary bucket. Behind that, humans have foraged for their food, and here we've taken that same body and we've put it in an environment where the stimulus for movement is very, very small.
Microvolumes. When you look at this dispersed pattern, it's made of polyhedral. You find all these fibers are intercrossing, intertwining, and the result are what I have called microvacuole, but microvolumes. These microvolumes are in the 3 dimension of the space, full either by glycoaminoglycan, either by cells, but it's the same shape. All these polyhedrons are different. So it's not exceptional. It's a rule. It seems to be the rule because we are a 3-dimensional architecture thanks to these fibers, organization in 3 dimensions. And you can explain also something very surprising. We are made of 85% of liquids. And how can we explain that we are able to grow against the force of gravity? How can we do that? This is surprising. And there is no explanation except the biotensegrity concept. There is also something interesting. It's the relationship between the vegetal world and the animal world. For me, the organization is the same. Of course, I don't want to say that a dog is like a tree. It's not my purpose. But the way how a dog is organized, with a fibrillar interior architecture, with a network as we are, is very close to the organization of a tree or a leaf. So it's the same way to organize the living matter, animal and vegetal. So thanks to this concept of fibrillar architecture, you can explain human anatomy, animals' anatomy, and the links between the nature, vegetal, animals. It's the same way, it's the same origin.
That concludes part 1 of The Secret Life of Fascia. Join us next time for part 2, where we explore underlying mechanisms. Till then, take care.